SPD trial was evaluates a cohort of the multi-arm STOMP trial, and it looks at the combination of Selinexor, pomalidomide, and dexamethasone at different dosing schedules for patients with relapsed refractory myeloma. Patients had a median of 2 or 2.5 prior lines of therapy, depending on which cohort they were in, and they were evaluated at 2 separate dosing schedules. So pomalidomide was given at 4 milligrams daily for 3 out of 4 weeks. Selinexor was given either at 40 milligrams once a week for 3 out of 4 weeks, or 60 milligrams once a week for 3 out of 4 weeks. And patients were very heavily pretreated. Significant portion were daratumumab exposed and refractory, and the majority were refractory to IMiDs and proteasome inhibitors. And despite that, we saw significant response rates. We saw a response rate of close to 45% in the Seli 40 milligram cohort and over 50% in the 60 milligram cohort. And even though the response rate was a bit higher in the 60 milligram cohort, the median PFS surprisingly was longer in the 40 milligram cohort. And the median PFS was not reached in that cohort compared to 9.1 months in the 60 milligram cohort. Both cohorts were well tolerated, with the expected toxicities that you would see with Seli and POM, including cytopenias, mostly grade 1, nausea, hyponatremia, but we can see that with the 40 milligram of Selinexor cohort, patients were likely able to stay on longer and thus achieve more durable remission. So I think this is an important regimen in patients who've had early relapse myeloma, and we can see durable responses with a lower dose of Selinexor at 40 milligrams. And this is going to be the dose that moves forward with trials in the future. The combination of Seli-Pom-Dex is both convenient in terms of all oral administration, very expected toxicities. We don't have unpredictable toxicities. We know how to manage them at this point forward. And we know that Selinexor has an add-on effect to almost all backbones that we use in multiple myeloma. Even in patients that are refractory to a particular drug, adding Selinexor can restore sensitivity. So it's much easier to tolerate, it's convenient, and it adds efficacy to pretty much any backbone that you're using in multiple myeloma. I think there's a role for Selinexor, both addition to a doublet or even to a triplet, and then even with the bispecific antibodies, Selinexor does synergize and in fact can prime T cells both for bispecifics and in bridging with combination in other regimens to CAR T cells. I think that MRD negativity, as important as an endpoint as it is not the end-all be-all, in particular for patients with high-risk multiple myeloma, because they relapse rather quickly, even after achieving MRD negativity. So we need to really look at T-cell fitness. How can we preserve our T-cell function in preparation for immunotherapies moving forward? And I think Selinexor is a great agent in that regard.